Yes. So this is patient of basically a overwide bony base with tip deformity, also have some functional problems, left side nasal obstruction, but particularly the concern of lady is regarding this and regarding this tip deformity. So because then on the left side, on this right side depression on the tip and this width, and she also have the bump
Right
of
side
this one.
depression
Yeah.
here and
Yeah.
over with here.
Yeah, over with here. So now basically after the infiltration, this depression is gone, but
You
yes,
mean infiltration? You mean
local,
local
yes,
painkiller?
yeah.
Okay.
No, local xylocaine.
Gyrocaine.
So we follow the 7 golden step. First step is the infiltration. So for better understanding of the infiltration, we have the 5 step of infiltration. Okay, the first step we infiltrate in the septum. Okay, give me the nasal speculum. So whenever we infiltrate in the septum, then forceps देना एक बार, forceps देना. So whenever we infiltrate the septum, then just when you infiltrate in the mucopericordial plane, then you have this ballooning rather than the blanching.
It's the same as septoplasty.
Yeah, as the septoplasty, same
Okay,
as the
okay.
septoplasty, same septoplasty.
Okay.
So local xylocaine with adrenaline 1:1 lakh, I already infiltrate just for the demonstration. This is the cold saline. So on either side, just we infiltrate this cold saline. In septoplasty, we infiltrate along the incision line. We have the 2 types of the incision. One is the Killian's incision. Incision basically the junction of the vestibular or the skin mucosa. That is the traditionally we use the Killian's incision. Another incision is the hemitransfixion. So that particularly use just prominent caudal margin of the septum. There is a new incision, modified Killian's incision. That term given by the Dean Teorumi. So in the modified Killian's incision, actually that is the junction of the vestibular skin, and behind this one, basically that incision is only in the vestibular skin. So according to him, the skin is more strength, so you have the less chance of the tear. But we just go for the open approach, so there is no modified Killian's incision or Killian's incision. So this is the first step. Now the second step for the transcolumella incision. So how you infiltrate? Just we hold this tip between the index finger and the thumb, and then between this tip defining point to the anterior nasal spine like this, and just we aspirate and then like this.
Okay.
Yes, okay. And then between the tip defining point like this, okay, and in this vestibular skin like this, and gauge piece dena. After the infiltration, just we massage it for the dispersal of this local, just like. So this is the second step of the infiltration. First is the septum, second for the transcolumella incision, and the third for the marginal incision. So just we use this wise double prong retractor, just like this, we invert it by the middle finger, and just we feel, give me the handle of knife, just we feel where we make this infiltration. So just we identify, you find some solid structure, this one, you feel, you hold it and just you feel some solid structure, you know, this one,
This one, yeah.
this one,
And
this is the caudal margin of the lateral crus.
Okay.
So along the caudal margin of the lateral crus, just we infiltrate like this,
Okay.
just we follow this one like this, okay, on the same, on this side also. So caudal margin of the lateral crus is the landmark for the marginal incision infiltration. Okay, so this is the third step. Now for the fourth step, for the dorsum degloving. So for the fourth step, where we inject the needle, we find the intercartilaginous area, the junction between the upper lateral and the lower lateral. Look that. This is the upper lateral.
Okay.
This is the upper lateral.
Okay.
This is the lower lateral.
Lower lateral. Okay.
So just we like this, and whenever we infiltrate for the dorsum, just we lift up this skin. Otherwise, sometimes needle comes like this. Go infiltrate and just go. Can you appreciate my needle? Look that. This is my needle. Okay.
Okay.
So just from top to bottom like this. But the important thing, we never infiltrate exact on the midline. We infiltrate on either side. Why? Because if you infiltrate exact on the midline, then it hide the contour irregularities. Okay. So just on either side of the 1 centimeter. So just on this side, this one.
Okay.
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 And just go like this. Okay. In this way. So this is the 4th step. Now for the 5th step, where we inject the needle, the landmark is the infraturbinate. For ENT colleague, it's no problem where we have the infraturbinate. This is the infraturbinate. Okay. This is the infraturbinate. So when we infiltrate, just lateral to the infraturbinate, along lateral nasal wall. This one. For the osteotomy. For the osteotomy.
Okay.
Just like this. Same on this side. So now the infiltration is complete. So we just follow the 5 steps. I again revise. First step in the septum, second step for the transcolumella incision, third step for the marginal incision, fourth step for the dorsum, and fifth for the lateral nasal wall for osteotomy. So I just follow the always these 5 steps of the infiltrations. Coach, please. Now the second step, that is the opening of the nose. So for the nose opening, we usually use the open approach. So whenever we make this incision, there is a lot of questions, a lot of conference and courses. I find the beginner friends have the 3 questions in the mind. First question, then which incision I usually first, because some people use this incision first, some people use the marginal incision. This is one confusion. Second, where we make the ideal incision, where we make, what is the site of the incision. Okay. And third common confusing questions, which type of the transcolumella incisions are we use, either the stair step, either the inverted V. So one by one be clear. The question number 1, then either first this transcolumella at the marginal incision, it doesn't matter. Some renowned such like my mentor Dr. Hossam, he used the marginal incision first. But earlier I used, but now since long time I use first transcolumella incision. Why? Because when I use the transcolumella incision first, then the rest of things on under my vision. Okay?
Okay.
Then the second important thing, then which type of the incision usually you use? I usually use the inverted V incision. Okay? Inverted E incision. एक ये नहीं देना मेरे को, वो बीटाडिन का देना और वो कर देना. Because there is 2 types of the incision that usually used in the rhinoplasty for the open approach. One is this one. This is the stair step incision. So many people use. Okay, this is the stair step incision. The problem in the stair step incision, when we open like this, later when the incision heal, then due to this soft triangle there is retraction in this area, and the patient have a more tendency of the scar due to the stair step incision. So I never use stair step incision. Okay. Now the second incision, that is the inverted V incision. So inverted V incision we use like this, like this, like this. Okay.
Okay.
So ideally the distance between these 2 points, that is the 3 millimeter.
3 millimeters. Okay.
Okay, 3 millimeter, and then the angle between this and horizontal limb, that is around the 60 degree. So almost it is just like a W. Look, that this is like a W.
Okay.
Okay, but whenever we use, then we use incision in the multiple break manner, zigzag manner. We never use the straight incision, because whenever you use incision in a multiple zigzag manner, then you have a less chance of the scar contracture. That's why we use incision is like a zigzag manner. Got it? Clear?
Clear.
And the third question, where we make the incision. So the third question is the most important thing, where we make the incision. We always put incision is the mid narrowest part of the columella. Mid narrowest part of the columella. So how we identify? Then this is the uppermost part of the columella.
Yes.
Okay, and this is the lowermost part of the columella.
Yes.
Okay. When you marking habit is very good. When you mark, then you learn better. Okay.
Okay.
So this is the mid nervous part of the columella. So just like this, just
Okay.
like this, then we make this. Okay, and then just around the 60 degree, like this, like this.
Okay.
So but now again questions, then why on the mid nervous part of the columella? Why? Because whenever we make the incision in the mid narrowest part of the columella, in this mid narrowest part of the columella, the margin of the medial crust, they have the more approximated with the skin. So during the healing, the force of the contraction is less, and again the patient have a less chance of the scar.
Okay.
First, and the second reason, because if you go down, then we have the very important tip support mechanism. Okay, if you have a very small columella, like if you have a light columella,
Okay.
then we have a different type of the incision. In that case, we have the, because we want to increase the length of the transcolumella, so in that case we use the incision like this, because we
Okay.
want to the increase the length, because after the lot of the projection it's very difficult to close the tip. Okay.
Okay.
So the clear the three questions. Okay, now give me the knife, because this is the first case, so you just observe the things. Okay,
Okay. Of
okay.
course. Of
So like how we make this incision, this is very important, because in open rhinoplasty, this is the only disadvantage of the for the patient, because patient have a fear of the scar.
Okay.
So this is very important. So just by this index finger and thumb, you hold this. Okay,
Okay.
and just you hold this 11 number blade. Okay, 11 number blade, and just make a stab incision like this, and you just pull it. Always counter traction is important. If you leave it like, then you use more. So just like, and then like this. Enough.
Okay. Enough.
Okay, then I use another blade, that is इनका 80 कर दो मैडम, I need the 80 systolic. ठीक है. Now for this incision, either we can make like this,
Okay.
or either we can make like.
Okay.
But if you use like this, then sometime accidentally you can damage the margin.
Margin. Okay.
So just always lateral to medial like this.
Okay.
Okay, and same on this side, lateral to medial like this.
Okay.
Okay, then again follow just superficially like this, and
Okay.
then same on this side. Okay,
Okay.
now we need a sharp scissor. Okay,
Okay.
hold firmly this one, pass this scissor from this side to the contralateral side, slowly, slowly. Once you reach in the mid part, then go from the another side, so
Okay.
you less chance of the injury. That's like this. And then from this side to the another side, ask your assistant, I am right or wrong. And now you have the support of the seizure.
Okay.
Okay, and just we complete this incision. Okay, we complete this incision. Now we have the set pattern. Now for further we need the two important instrument. Okay, give me these two instrument. For further dissection we use always single hook and double hook. How we use this? Like this single hook is like this, single hook dena, single hook like this,
Okay.
and the double hook we use
Like this.
like this. Okay,
Okay.
now I show you a very important thing. This is Mukesh, move karna yaar. This is, look that. What is this thing?
Sep,
Columellar
Columellar.
artery. You see the columellar vessels. This is the columellar artery. Beautifully you can
columellar
see.
artery.
Yeah,
Okay.
because there is a facial artery that have the two branches. One is the superior labial artery,
Superior
another is the
labial
angular artery.
Angular artery.
So this superior labial artery have some branches of the columellar
Columellar artery.
vessels.
Okay.
Okay, beautifully visible. Okay, so just we cauterize it. Just we cauterize it. Pencil लगाना. Just we cauterize it. So just we, okay, and now first always we just take a seizure in a pen holding position,
Okay.
and then we just feel this is my right side of the medial crus,
Okay.
and then you rotate it, and this is my left
Left
side
side
of the
medial
medial
crus.
crus.
Okay.
You feel both these things, you just hold, feel. This is your right side margin of the medial crus. Got it?
Got it.
And then you rotate it, and this is your left side.
Left. Okay.
Or margin of the medial crus is intact. So our incision is good. Otherwise, sometimes what happened when people blindly they pass from the injured
Puncture.
and then they panic. Oh,
Oh. Okay.
okay. So now for further dissection, we use 1, 2, or 3 like this. Okay.
Okay.
And then this is the soft triangle area. So just we spread it and cut it.
Okay.
We spread it and cut it. Just like we spread it and cut it along the caudal margin of the lateral crus. So this is the caudal margin of the lateral crus.
Okay.
Okay.
Yes.
Now give me the वो देना मुकेश से लगाना. हाँ ये लगाना. Now on this side marker देना. Give me the marker. ऐसे लगाओ. Give me the marker. This is the caudal margin. पकड़ना.
That's the caudal margin of the
Lateral
lateral
crus.
crus.
Lateral crus. Come, hold this seizure. Come,
Like a pencil?
Yes. Just no.
Ju-
You just make this incision. Try to make this
Try
incision.
to make this incision. Okay.
Just along this marking, along the marking. Section देना मेरे को. I show you. Yes, along my line. Yes. So this is the margin. Okay.
Is
This
enough
is,
or
yeah, more, little bit more.
little bit more? Okay.
Yes. Okay. Okay. हाँ जस्ट चेक मुकेश थोड़ा सा और करना है मेरे को देखता हूँ उसको लगा होगा
Okay. So
because there is
That far
little bit
away.
injury.
okay.
So now we complete the transcolumella and the
Okay.
marginal incision.
Okay.
ठीक है ना? And now give me the wide. We need for further 3 instrument this wide double prong retractor.
Okay.
So how we use this one? Like this,
Okay.
and just small wide double prong retractor like this,
Ah, like this.
like this. Okay. And now like this. This is the 3-point traction, 3-point traction point technique of Dean Torumi.
3-point traction.
3-point traction, 1, 2 and 3.
3. Okay.
When you have a counter traction, there is no bleeding.
Okay.
Okay, there is no bleeding, no bleeding. So then now by this instrument, just you can beautifully, you can enjoy your dissection.
Okay.
Okay. Now on this side,
Paradoxical.
yeah.
Paradoxically controlled.
Yes, paradoxically. Now, same like slowly, slowly, look that. So beautifully, you enjoy your dissection, okay? And now, the name of this structure, come teach Mukesh. This is the ligament of the
Pitagoya.
pitangoi. Yes. So, we just cut it like
Okay.
this. थोड़ा सा इसको now little bit more exposure on this side. Okay. Now we change the position of this instrument like this, because just we go again, we find a net like structure. Yes, like this. Again we find this net. So just you just come and just you swap it. Yes, swap it.
Here.
Yeah, here, here,
Here.
Yes.
Okay.
here, slowly, slowly. Yes, this is the mid vault.
Mid-wall.
Yeah, upper lateral cartilage
Upper
area.
lateral cartilages. Okay.
Yes, upper lateral cartilage area. Yes.
Okay.
Okay.
How
Now,
far should I go with
yeah.
this?
Basically, superior limit in this area or lateral limit. Lateral
Okay.
limit 1 centimeter,
Okay. So
and superiorly at the level of the intercanthal line.
so I should go like.
Yes.
Okay.
But before to that, we need change the instrument.
Okay.
We need some net like structure. वो देना दूसरा. We use this off reach.
Okay.
So then now you have the better visibility. Look that. You have the better visibility now. Just mop it. Yes, go. Yes. Now again, the matter is the plane of the dissection, you know. So in this area, the plane of the dissection, that is the supraperichondrial. Okay, suprapericordial, because this is a thick skin patient.
Okay.
If we go the subpericordial, then we weak lateral crus. Okay,
Okay.
in this area also we are the suprapericordial.
Suprapericondial.
Suprapericordial.
Supra.
Now again we just go the supraperiosteal or subperiosteal. It a matter of the question.
Okay.
But my patient have a bump on the dorsum. I want to do some rhinosculpture. So I
Okay.
want to go the subperiosteal. So for the subperiosteal I change my plane. So how I change my plane of the dissection? This is the mid vault, okay, and this is the bone. So first I create a space in this. Now in this area, so this is the bone. So just I make a incision in the periosteum. Look that this is the bone.
Can I feel the bone?
Yeah, feel the bone.
Okay.
Okay, so I just feel the bone. One incision on the bone, just like this.
And the second one on the other side.
ओके इसको अच्छे से लगा. Now I just changed my plane of the dissection. Look that this is my bone. Suction ले ले हाथ में यार. Suction. So this is the bone.
This is the bone. Okay.
Okay, and on this side also this is the bone. I create a tunnel on both sides. Okay, and now I join this both tunnel.
Okay.
So I just expose. Now on this side. Laterally, ideally 1 centimeter is enough. But if you want to do the rhinosculpture, some
Okay.
rasping, then
Okay.
you need the more exposure. Okay.
Okay.
Now on this side also, till the nasofacial groove, till the nasofacial junction.
Okay.
So look there now. This is the intercanthal line on either side. Complete exposure.
Okay.
Okay. Now we have very beautiful this instrument. So this is the self-retraining retractor. So now you hold like this. Okay. एक कॉटन की पेटी रख देना. कॉटन की पेटी रख देना. उजिन कहाँ से आ रहा है? कॉटन पेटी रख देना. टूथ फॉर्स सब देना. काटो इसको थोड़ा सा. प्रकाश को बुला के वीडियो बना देना.
बना रही हूँ सर मैं वीडियो.
ना इसका बनाना है ये
अच्छा,
और
इसका
जो.
हो गया.
ये यहाँ पे उजिंग मुकेश दिखा इसको. देयर इज सम उजिंग इन दिस एरिया. सक्शन दिखा. सो वी जस्ट cauterize it. कहाँ से आ रहा है दिखा. यहाँ पे दिखा. कहाँ से. हाँ वो है यहाँ पे. She has some trauma in childhood, so there is little bit fibrosis. Okay. इसका बना रहे, इसका यहाँ पे आके यूँ और यूँ बीच में। So once we examine the patient, you know, in the your OPD, then such type of the patient, when you see just above the skin, then in your mind just you just imagine that such type of the deformity on underlying the patient have. So when you examine, then we discuss in the boardroom that like the patient
The
have this
lateral
deformity.
cross.
Yeah, that's
Yes.
why she has the depression. Okay.
Depression.
So now, tooth force up देना. The next step, we expose the septum.
Okay.
Because we expose the lower lateral, upper lateral and nasal bone on either, but now we expose the septum.
Okay.
Then for the septum exposure, traditionally we use these two instruments.
Okay.
How we use these two instruments? Just this is cartilage holding forceps,
Okay.
just like this and just like this.
Okay.
This is cartilage holding forceps.
Okay.
Just like give the counter traction in the
Okay.
anterior inferior direction. Hold this one, and then we use the seizure. How we hold the seizure? Just like, and one your finger that should be on this junction for
Okay.
better balance.
Okay.
And then we separate this one. This is a very easy technique for my beginner friend. Separate it and the cut it. This is the interdermal ligament.
Interdermal ligament.
Yeah.
Okay.
Yeah, we cut it interdermal ligament, and then again we separate it and cut it. And you have to know then what you want to identify. We want to identify the caudal margin of the
Caudal margin of the
septum. You have this glimpse of the septum.
Okay.
You have the glimpse of septum. Now earlier we hold like this. Now we
Okay.
change like this.
Okay.
Yes. Again you find the good plane of the dissection. Okay. So then just we cut it. Okay. Now give me the sharp scissor. Just we hold in a pen holding position just like this. Okay. And then
These are the
pen holding position. Sharp scissor. Sharp scissor. Then we find the mucoperichondrium. We just degloving this mucoperichondrium. Where we degloving? In the superior most part, because if you study the septum, then the superior most part of the septum then less densely adherent with the mucoperichondrium. So it's very better and easy place where you can get maximum the plane of the
Okay.
dissection. And this is one of the most difficult step in a pediatric septorhinoplasty, in a secondary cases, in a post septoplasty cases, because the patient have a fibrosis. Okay. So suppose if you
scar
have,
tissue.
yeah, if suppose you have a very lot of bleeding in this area, you have
Okay.
a tear in this area, then
Okay.
you change your site and wait for
Okay.
some times. Never lose your patience. And then now for further, this is the Store's periosteum elevator. So
Mhm.
just we go slowly, slowly, like this, like this. I just deglowing my mucoperichondrium on under surface of the upper lateral cartilage.
Yes.
This is my upper surface of the upper lateral cartilage. Okay, so I create a pocket, and on this side also, just I create a pocket. Just I create a pocket. Now, give me the 15
So
number
with
blade
this tool, you are going between the upper lateral
and the septum.
Okay.
Yes. So now I just separate. I separate upper lateral and the septum. I separate the upper lateral and the septum. Okay. Now you use this lateral crura retractor. I have this lateral crura retractor.
Okay.
So now everything in front of you, everything in front of you, you can enjoy your surgery. Everything in front of you now. Okay. And
Can I ask something?
yeah.
So that's the upper lateral.
This is the left side upper lateral.
Left side.
Yeah, this
the
is the right
and
side
that's
upper
the
lateral.
septum.
That's the septum. Okay, that's the septum. Okay, now we find ideal plane of the dissection. How we find the ideal plane of the dissection? It's a very easy method. नीचे गॉज पीस गिर गया उठाना. So now just we hold this one just like, and then give me the 15 number blade. So by back end of your knife, by back end of the knife मुकेश से move करो और इधर ध्यान दो. By back end of the knife just like this. Yes, give me the sharp scissor, and now by this sharp scissor, look that you see the difference. मुकेश अब उसको पकड़ो. So look that this is the ideal plane of the dissection. And the septum is deviated on that side.
Okay.
Here a groove.
Okay.
Okay.
Ooh.
So just look, the septum is fractured in this area.
Okay.
Just hold this one. This is the ideal plane of the
Okay.
dissection. So things are changed. If you are not in the ideal plane of the dissection, you have a more chance of the tear. Okay. Then just slowly, just look that. No
Okay.
bleeding.
No bleeding.
No
yeah.
bleeding. You enjoy your surgery. Everything in front of you. So again, there is a sequence. Then which sequence you degloving your mucoperichondrium? So first anterior superior, then just go the posterior inferior, and third in the posterior superior, and in the last in the anterior inferior. Why? Because in the anterior inferior there is a dense mucoperiosteal attachment. Okay, so just go like this, like this, like this, like this, then go superiorly like
Superior,
this,
okay.
like this. ये कॉटन की पेटी डाल दो, जस्ट कॉटन पेटी अंदर डालो. Now on this side we find the ideal plane. Same manner, just bleeding क्यों? Just by the back end of the knife.
Okay.
Okay, back end of the knife, yellow, and sharp scissor. Give me the sharp scissor.
Okay. I see.
You appreciate?
Yeah.
The mostly people usually go in this line,
Yeah.
so that is wrong. Look that things are changed. Beautiful plane.
Beautiful.
Beautiful plane. And now nasal speculum dena. Give me the nasal speculum. Why we have this bleeding? Yeah. So just फेंक देना मुकेश, और वो लगाना, वो जस्ट चेक करते हैं. एक एंडोस्कोप, just I show with the endoscope why we have the bleeding. Usually we don't have the bleeding because the BP is good. Then why we have the bleeding? लो 0 डिग्री एंड वो देना. नंबर दे देना. और एक कॉटन की पेटी और दे देना, कॉटन पेटी, जस्ट गिव मी द कॉटन पेटी। गोज पीस और रख देना। ये लो, ये हटाओ। So we just check from the inside। उसको बोलना ऊपर की लाइट बंद करे कोई, ऊपर की लाइट बंद कर। So suction, सेवलॉन, लेटरल क्रूरा रिट्रैक्टर लगाओ, लेटरल क्रूरा रिट्रैक्टर इधर भी लगाओ। Yes, forceps, give me the forceps, लेटरल क्रूरा रिट्रैक्टर में खींच दिखा। हाँ, yeah, we have some trauma in this area. From here you have a bleeding. That's why I just check why he have that so oozing. मुकेश को मंगा ले काला। This is the part where he oozing. Look that. दिया ना, काला वाला दिया। पोट्री लगा ना। देखिए पहले कहाँ से हो। यही है ना, ये लगा। लगा पीछे है। लगा। पैकिंग फोर्सेप देना, पैकिंग फोर्सेप। पेशेंट फील कर यार, क्या कर रखा है मुझे। ये ले, इरिगेशन कर अंदर। ये लगा दे यहाँ पे, लगा। बस ठीक। लगा ठीक sometimes we have some unusual bleeding.
Yes.
Now we expose completely. Posteriorly also we just put the peg.
So
Okay.
you used the endoscope especially for the bleeding.
Yeah, for the bleeding, I just because usually whenever you have the bleeding, the first most important reason you are not in anatomical plane. First, second, your blood pressure is not normal. My patient blood pressure is good, my anesthetist is good, plane of the dissection is good, but it's unusual. Unusual. पैक लगाया. Now दूसरी तरफ भी देखते हैं. Now on this side दिखा मुकेश. ठीक है, पैक डाल देना. पैक, गिव मी द पैक. जस्ट वी डिस्कस सम एनाटॉमी. उसको बोल ऊपर की लाइट जलाए. पैक डालना है, पैक डालना. ये लगाऊं यहाँ पे. Put the endoscope on the baton. 0 डिग्री रखो. इसको रखो. पेशेंट को क्लीन करो. So we expose the septum also. So exposure part is now complete.
Okay.
Still I am not cut any septum or whatever. Just for the understanding of the anatomy was just. Watch piece देना. एक दूसरी सीट और मंगा लेते हैं. Tooth portion. So this is our right side of the lower lateral cartilage.
Yes.
This is the left side of lower lateral cartilage. Okay. This is septum.
Yes.
Okay. This is dorsal part of the septum.
Yes.
This is caudal part of the septum.
septum.
So the junction between the dorsum and this caudal, this is the anterior septal angle area.
Anterior
Septal
angular area.
Yeah. This is the anterior septal angle.
Okay.
Okay. Clinically, this is important. Otherwise, theoretically, this is the mid septal angle, and posteriorly, where it attaches with the posterior septum,
Okay.
we have the posterior septal angle. Sharp seizure देना. Sharp seizure देना. Just I separate. These are some depressor septa in agile muscles. मुकेश इधर भी ध्यान दे. Yes, lateral crura retractor. So this is septum. This is upper lateral cartilage. This
Upper
one.
lateral cartilage.
This
Yes,
one.
this one.
Okay, this one. Okay, this is left side.
Left side. Okay.
If we see the tooth forceps then one by one, then the junction of this upper lateral
with the
and this septum, this is nasal valve area.
okay.
Because this is mucoperichondrium.
Mucoperichondrium.
Okay, this is upper lateral. This
Yes.
is internal nasal wall area. Okay, and on this side same. If you go from the inside, this is the upper lateral.
Okay.
Okay, internal nasal wall area. And now this is lateral most part area. This is the
Yes.
lateral crus.
Lateral cross.
this is medial crus,
crus,
okay, and this is intermediate crus,
intermediate crus.
okay. Now in this medial crus, this is the foot plate
Foot
part
plate,
and this is columella
columella
part,
part.
okay.
Tak.
And in this intermediate crus, this is domal part
Domal part.
and this is lobular part,
globular part.
okay, and this is lateral crus. So this lateral crus have the two margin. This is the cephalic margin,
Cephalic margin.
this is the caudal margin,
Caudal margin.
this is medial end, idhar dikha, this is lateral end, this
Lateral
is
end. Okay.
लगम के, this is lateral end and marker भी देना. So the area we discuss at that time, there is a overlapping between this and this upper lateral cartilage.
Yes.
This one, this is scroll area.
Scroll area. Okay.
This is scroll area.
Okay.
It usually hide like this.
Okay.
This is scroll area.
Okay.
Okay, and we follow the incision, always marginal incision in this area. Okay, and the shape of this, that is little bit concave. So this is paradoxically concave, paradoxically lateral crura deformity. Okay, and this is the dome part. So usually we have the tip defining point on the surface of this part.
Okay.
Okay, the distance between the tip defining point is this 6 to 8 millimeter in a female patient and 8 to 10 in a male patient. So the width of the tip is basically depend on the distance on between two. Okay, now at that time we just discussed, look that the divergence, angle of this dome divergence, this is normally 30 degree.
Okay.
If you have a more than 30 degree, then you have a
Broad.
boxity.
Okay.
Boxity. Okay. If you have more distance, then you have broad tip.
Broad tip.
Angle of the more dome divergence, then you have a boxity.
Angle boxity.
Yeah.
Distance broad.
Broad, yes. And this is the basically angle of the dome. This
Okay.
is the angle of the dome. Okay.
Okay.
This is the angle of. If the distance between this one and the distance of this ala base, that the index is more than 0.6, that is the bulbous tip. That is the bulbous tip. Okay, that is the bulbous tip. Now we in the lecture we discuss a soft triangle. Why we have the soft triangle? Look that this is the dome part, and in this dome part we have the good support, and now we lost the support.
Okay.
This is the soft triangle area.
Okay.
Got it?
Got it.
This is the, so that's why in this area we have very dense skin to skin approximation.
Okay.
We don't have the good support. So due to the human biting and due to the any injury, the patient have a notching in this area. Okay, notching in this area. So that's why when we just rotate in this dissection at that time, then you have be careful. This is the soft triangle area. Now another one important thing, there is a relation between this one and this structure.
Okay.
You know, ideally there is a relation between this structure and this structure. Okay, this structure, that means the dome that should 1 centimeter anterior, that means forward. Suppose this is the anterior septal angle.
Yes, sir.
So this is 1 centimeter
Above.
forward and 0.5 centimeter anterior.
So this
Yes, this dome.
creates dome,
Yes,
which is 1 centimeter forward,
Forward,
from the anterior
septal angle area. Yeah, and 0.5 anterior. That's why we have the supratip break. That means there is a break. That means the dorsum end and the tip little bit higher.
Okay.
This is the concept. This
Okay.
is the concept. Okay. This is the relation between this structure. And ideally this septum is protrude between this medial crus around the 2 millimeter. If more than, then you have a hanging columella. And
Okay.
if you have the less, then you have the retracted columella. Got it?
So the caudal margin of the septum is protruded 2 millimeters.
2 millimeter.
Like this.
Yeah.
Okay.
Okay. So now we discuss the anatomy, and now just we harvest the septum cartilage. Okay, we harvest the, put the lateral crura retractor. So when we harvest the septum, then we just preserve around the 1.5 centimeter superiorly and 1.5 centimeter anteriorly, just to maintain the L strut, just to maintain the L strut and maintain the integrity of the dorsum and the anterior part
Okay.
of the septum.
Just
So-
like we do in septoplasty.
Just like a
in
septoplasty.
Okay.
Yeah. So that is not a big things for you, but just we can 15 number वो देना marker दे देना. You hold this one little bit, show me. So almost just like this.
1.5
Yeah,
centimeter
1.5 centimeter.
superior.
And 1.5 this one, but we have the
The-
fracture, so we
the
just
groove.
along the fracture we move
Okay.
like this.
Okay.
Okay, kilo, give me the. So just you make incision, follow the line, follow the line, follow the line. Yes, follow the line. Yes. Go along the line.
Finish this incision.
Yeah.
There it is.
Yes. So at the junction, we never go acute, just little bit. If you
Okay.
have a acute angle, then you have the more chance of the.
Blood supply.
Yes. So just we like.
Okay.
Okay.
Like that.
Yes.
Okay.
Look. Now we need this long Killian's nasal speculum, and then just make the space. एक बार इधर से निकाल दो. We have the pack. निकाल दिया pack. Okay. Okay. Put it. Just we remove on this one. So whenever you have the bleeding, then you just pack little bit, wet for some times. Okay. Now we pass from this side to this side, like this.
Okay. Like in septoplasty.
Yes, like in septoplasty. 15 number blade देना. Because still we have the attachment anteriorly, so just go deep, just like this. Now we separate superiorly, anteriorly, but still we have the attachment posteriorly. Okay, so for the removal of the posterior attachment, I use this. So by this sharp instrument, I just go posterior and just I
Break.
break.
Okay.
Slowly. Now still the inferiorly we have the attachment, so just now we check. This is rib holding forceps,
Okay.
so just
We will-
suction.
I can hold if you want.
So this is the septum.
This is
Suction करना मुकेश.
Okay.
Okay, this is like this. ऐसे था.
Okay.
Like this.
Like this.
Yeah, this is the PP plate attachment.
Okay.
This is the superiorly. This is the anteriorly. This is the part where you have the fracture.
Okay.
Okay.
The groove.
Yes. Really.
Okay.
And now just Periosteum देना मुझे, just give me the periosteum. Forceps देना. ये पकड़ना. So सीजर देना, सीजर. Turbinate सीजर. Periosteum. Forceps देना. Not. So I just in the warmer part. Taking forceps देना. So whatever amount, as much as bigger piece, so you can use for the reconstruction. Yes. Give me the tooth forceps, lateral crura retractor. Okay. So this is your septum.
Oh, septum.
This is your septum. Okay.
Okay.
So look that this is anterior septal angle.
Yes.
This is mid septal angle.
Yes.
This is the posterior septal angle.
Posterior.
Okay. This is the posterior septal angle. Irrigation सफाई. Now tooth forceps. एक tooth forceps देना. Just give me the tooth forceps. So 15 number. So some excess part we remove because it gives the push pressure effect on the septum.
Okay. So you removed the part of the septum, but now now you are removing the deviation.
Yeah, deviation and some excess part.
Axis part. Okay. Okay.
इसका septum भी थोड़ा S shape ना.
हाँ, because ये this is the convex septum.
Yeah.
This is the concave septum. So we correct it whenever we move because इसको पहले 4 से वो कर लेते हैं. So now we refix it again in the anterior nasal with the anterior nasal spine because now the septum is free.
Free.
So we fix it. So
with the anterior nasal spine.
Yeah, with the anterior nasal spine.
Okay.
You can see
Can
this
I-
is the
can I feel it?
just this is the anterior nasal spine. You
Okay.
feel
Okay.
this
I
is the anterior
understand
nasal.
now.
Okay, this is the anterior nasal spine. This is the anterior nasal spine. This is the groove where the septum usually lies.
Okay.
Okay. So we just fix
Just
like
that.
this.
Okay.
You just hold this one, hold this one. So for the fixation, usually we use this 4OPDS suture.
Okay.
Okay, this 4OPDS suture. So either you can make a hole in this because just like a Caucasian, it's a big
Okay.
anterior nasal spine,
Okay.
long anterior nasal spine. Or second, just we pass through the periosteum. This is the easy method for my beginner friend.
Okay.
Just go from this again So the periosteum of the
Okay.
anterior nasal spine.
So on the both sides.
Yeah, on the both
Okay.
sides.
Make to make it central.
Yeah, make it central.
Okay.
If this is in central already, there is no need to do anything. Okay, this is easy methods. Either some people they make a hole in the
Okay.
antenasal spine with Linderman bar, but for my beginner friend it's little bit difficult. So how you make the easy things, that is my motto. छोड़ दो. So now is it fixed?
Okay.
Yeah? Yes, पकड़ो. Tooth forcer. So after the infiltration, first step, after the exposure, second step, the septum part is complete, third step is complete.
Okay.
Now we move the fourth golden step for the bony pyramid modifications. Just we pack it, tooth forcer both डाल दो इसमें, cotton patty डाल दो. We just put the cotton patties because now the septum is free. So we just give the counter support on the both sides. One on this side.
Okay.
So now we have the two options. Then either just go the directly the lateral osteotomies or whatever the osteotomy part for narrowing of the orbit, wide correction, or some just do the some rhinosculpture, some rasping. Either we have the piezo, we have the cylindrical bar. Either you can use the rasp. Okay.
Okay.
So we use the drill लगाना.
Okay.
ड्रिल लगा लो.
drill लगाना. प्याजो का वो है क्या काटने की प्याजो नहीं लगाए. I always you should have your photograph in front of you in your OT, so at least we know that. लगा दे गए. ये लगाना. लो.
But assuming, looking on this photo, I assume that there is no need to much of a drilling. Yeah.
Yeah,
Because the hump is very small.
yeah, hump, but we just drill the lateral nasal wall.
Ah, you
Yeah,
drill the lateral
yeah,
wall.
yeah.
Okay.
We need
Okay.
the lateral nasal wall.
Okay.
We drill the lateral nasal wall. And this is the good. This is the suction elevator.
Suction.
Yeah.
Okay.
This is Goxel.
Okay.
Yes. You know the Goxel? This is a Turkish plastic surgeon.
Okay.
Innovated by him. उसको बोलना है इसको सीधा करे यार. चले कहाँ जाते हैं वो.
Paper.
दीपक प्रकाश.
Why this time you decide to drill rather than make an osteotomy?
The reason, if you do the osteotomy directly, definitely you can do and you can complete the case by only osteotomy also. But if you do the rhinosculpture, then the osteotomy is easy because the bone is thin.
Okay.
Okay?
Okay.
And you have the more elegant nose later.
Okay.
Because he complained my nose is too bigger.
Okay.
Okay? That's
I
why.
understand.
कहाँ गई इधर?
Deeper.
पकड़ना मैं बोलूँ. ओमी, वो लड़के होंगे ना यहाँ पे, कहाँ गए? बोलना. उनको बोलना. तुम्हारी बहुत गंदी आदत है, किसी के मैं रख दूंगा. तो डेमोस्ट्रेशन चल रहा है, कोई नहीं होते तुम. इधर वो ड्रिल नहीं चल रही. Because this part, na,
Okay.
this part is the thickening of nasal bone.
Okay.
By the osteotomy, you can't reduce the thickening, you reduce the width only.
Okay.
You got it, my point?
Oh yeah, I got
But
it.
by the rasping, we reduce the thickness because she's a
Okay.
female patient. She wants a narrow, elegant nose.
But with the osteotomy, you can't really reach that area.
Yeah.
Okay.
चल रही. क्या जो लगा रहा है क्या देखना.
वो लगा रहे हो मशीन?
वो कहाँ गया प्रकाश? Suction, irrigation. Now on this side, ला इधर. So I am drilling the ascending process of the maxilla.
Okay.
Okay. So that's why we expose till the level of the nasofacial junction.
How do you know
How
how
much,
much
yeah,
drilling is enough?
Yeah. Yeah, this is when you do the continually, this is your aesthetic sense. Then otherwise you just leave it and again you just check it
Okay.
like that, how much like this one.
Ah, okay.
Yeah, otherwise.
This is the question I also
Yeah, yeah, this is the aesthetic sense only.
Yes, sir.
This is the aesthetic sense only. Because still we need little bit more.
Okay.
But a little bit more.
Oh,
Yeah.
there is a here.
Yeah. Okay, Zika. Okay, Zika. चलाएं डालो. So just now, okay, comparativity is narrow. एक वो बिटाडीन और वो दे देना. You use routinely for the osteotomy, the piezo and osteotome. What you use in your hospital?
In Poland, what we usually use?
Yeah.
Oh, I don't know. As my, second operation, which I observed. So the guy was using only osteotome. Okay.
This is the superior part.
Yes.
Okay. And this is the nasal bone.
Yes.
This is the nasal bone.
Yes.
This is nasal bone. This is ascending process of the maxilla.
Okay.
And this is soft triangle.
Okay.
This is soft triangle. Okay. So the goal, we want to free the attachment surrounding medially, laterally and superiorly. So for the remove the attachment, we use osteotomies. So osteotomy is a controlled fracture of nasal bone and ascending process of the maxilla for getting the desirable width, for getting the desirable shape of this bony pyramid. So there is a lot of bias, the people confuse medial, lateral, transverse, intermediate. So basically never need to be the bias, it's very easy. If we just separate, if you medial part of this lateral nasal wall, then this is the medial osteotomy. When you separate laterally, that is the lateral osteotomy. When you separate superiorly, then it's the transverse osteotomy. And the part between the medial most and lateral most, this is the intermediate osteotomy.
Okay.
So these are the different osteotomy that usually we use for correction of this bony pyramid. The goal of all these osteotomies are same. We reposition this bony pyramid for getting the good desirable width, for getting the good dorsal aesthetic line. Indication for the medial and for the lateral osteotomy, the indication are same for straightening of a deviated dorsum, for narrowing of a broad nose, and sometimes rarely when you have a pinching of the nose, where you have a very pinching of the nose, then for the widening also. For correction of the open roof deformity, for correction of the inverted V deformity, we use different type of this medial and lateral osteotomy. Indications are only different of the intermediate osteotomy. Intermediate osteotomy usually we use when one side of the nasal bone is longer than other, when one side of the nasal bone is more thicker, more convex, then we use the intermediate osteotomy.
We
Okay.
can see it on CT scan.
Yeah. Why we use the intermediate osteotomy? Because in that case we need the multiple more movement of lateral nasal wall. You know, we need the multiple more movement of the lateral nasal wall. So we need the multiple fracture of the lateral nasal wall, medially, inferiorly, because we're getting the more movement. Okay. So these are the indication of the intermediate osteotomy, but the important thing, the sequence of the osteotomy is also important. If you go the medial or lateral osteotomy, it's hardly matter, but if you use the intermediate osteotomy, then first osteotomy you use the intermediate.
Okay.
Why? Because suppose first you do the lateral osteotomy, in a destabilized lateral nasal bone, how can you do the intermediate osteotomy? Okay. So first you use the higher osteotomy, and later do the rest of the osteotomy. Okay. And suppose one side is the concave and another is the convex. So which side do the osteotomy first? Suppose your nose is just like this. This is the convex, this is the concave. On which side you do the first? Yeah, convex. This is the one commonest mistake done by beginner friends. Because suppose first you do the convex side, then this part resists to allow in the midline. How can you move this part? Because there is another person that pushed their lateral nasal wall. So you use first you free your concave side to getting the allow this convex in the midline. This is the common mistake done by the beginner friends, and then they struggle a lot of it. Not straight. First you do the concave side and then the convex side. Got it? So this is the important, the sequence for correction.
Let me repeat.
Yeah.
That's the medial,
Yeah.
intermediate,
lateral
and
and transverse.
Okay.
Yeah. Transverse osteotomy usually we need when the root of the nose is deviated. Root of the nose is deviated. Okay. So in this patient we use the piezo. वो देना. So we use the piezo. So for every osteotomy, you know the important thing, which osteotomy use. So that means where you place the instrument, either the piezo, either the osteotome. So we place this in a parasagittal manner. This is the midline, but we use this just few millimeter lateral.
Okay.
That's why we call it the paramedian osteotomy.
Paramedian.
Yeah. just 15 to 20 degree fade away condition. Okay, lateral के लिए देना
15 to
20 degree
20 degree.
या fade away condition.
Okay.
लाओ वो देना lateral के लिए, यही है.
This uses high pressure water to cut.
Hmm?
They also uses high pressure water to cut the wound.
This is the principle is the different of the charge. So we cut this lateral nasal wall, ascending process of the maxilla and medial attachment of the nasal bone. Okay. Now give me the osteotome. Section देना, ये रहा. So another side I demonstrate with the osteotome. Okay.
Okay.
Okay. The another side by the osteotome.
So on one side piezo and
Yeah,
on the
I just
side.
for you.
Okay.
So where we make the incision, just we find like this. When we drill, that sometimes we have these holes, we suture it from the inside, but this should not be happening.
Okay.
And this is the infiltrabinate. Okay. This is the infiltrabinate. Okay.
Okay.
So just to lateral to the anterior node of infiltrabinate, we make a horizontal 3 mm incision. This is infiltrabinate.
Okay.
So just in this groove, like this.
Okay.
Okay, and then we engage. This is the osteotome. This is the guarded osteotome. So in the guarded osteotome, this is the guarding end. This is the cutting end.
Okay.
Okay, so we just engage like this.
Okay.
Okay, just at the 70-degree like this, and I feel my guarding end like this,
Okay.
and ask my assistant two tap technique, tap tap like this. So Mukesh, tap tap, and go gradually down, tap tap, tap tap, tap tap, tap tap, tap tap, tap tap, stop. So now I am just on almost on the parallel. Earlier I hold like this, now I just hold like this. Okay, and then throughout I feel, because there is a variation, I just feel just, and then just give you that. Now you feel, Peter, you feel the guarding hand. No, I just give. Now you feel.
Oh, sorry. Yes.
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 Yeah. Here look there. Once we reach at the medial level, then displacement chance you have the maximum. Mm-hmm. 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 Just stop. So I show you where we are actually. Dikhana, uthana. What I am doing. Suction, do the suction, and just look that this is,
Oh, I see the
yeah, this is my guarding end.
guarding end.
Okay, this is, I
Okay.
break this one.
Okay.
Okay,
I see now.
okay,
Yeah.
I am breaking this one. Marna, tap tap, 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 tap tap. Yes,
You are turning.
yes.
Okay.
Pakadna. More, little bit more. So upper limit is the intercanthal line. Yes. So now on the left side, I rotate it on the anti-clockwise manner. On the right side, on the clockwise manner.
Okay.
Now comparative, the nose is narrow. Okay. Now it break. Give me the bone mobilizer. We have this bone mobilizer. So now, according to we need where we place the bone, because now the bone is free, so we can place it.
So you pushed the bone inside,
Yes.
and now you are putting it with
Yeah.
this
Just by
outside.
the outside,
Okay.
inside, where we
Just
want
to
to fix
control
it.
it where
Yeah.
it is.
Yeah.
Okay.
So if you compare it, now nose is narrow. Earlier look
Yeah.
that nose is too wide. So we can do by this osteotomy also, just for your demonstration. Just
Okay.
one side. What is the, basically you clear your concept where we separate it.
Yeah.
And now we put,
With the piezo is easier.
yeah, passages is it? That is
Easier.
more sophisticated way. This is a female patient. Sometimes we have a male patient, too thick bone. In that case, the osteotomy is good, or otherwise first to do the rhinosculpture. So otherwise, piezo be good, but the tip is broken. In some few cases, the tip is too costly.
Okay.
This is the problem.
Okay.
For the lateral osteotomy, that we have a long tips, Goxel tips.
Okay.
One tip cost is around $400.
$400. Okay.
Yes, $400. That is costly. La. Yes. So cold saline, put it cold saline. So we complete the fourth step. Now we move the fifth and sixth. Okay. This is cold cell lines. So now we put it
Okay.
just for the hemostasis, because after the osteotomy we have some oozing, little bleeding. Now the problem, we have only this part of the septum. That is tentatively not enough. This is not enough. कॉन्कर लेना पड़ेगा, क्योंकि इसको लिए कहाँ से लाएंगे? नहीं, ये तो अपने को इसी में हो जाएगा काम. Because now we need the more material, but we have very limited material. Because that part is only for the septal extension graft. So I think we just go for the concal, क्योंकि दोनों उसके लिए चाहिएगा ना. So we have only option, we just go for the concal cartilage. We need the concal cartilage.
Okay.
Otherwise, how we correct that defect, depression? So we harvest the concal. Okay. मेरे को लोकल दे देना. लोकल देना, फिर ग्लव्स दूसरे खोलना. पहले लोकल दे दो. यार तुम एक जना यहाँ से जाओगे नहीं.
लोकल लेने हैं.
अपने पास अपनी वो सिरिंज थी ना मुकेश, देना, इसमें ले लेते हैं. So just we infiltrate. नहीं है कि निडले. ये तो उसमें डाल देना. ये तो भी स्टाइल ही है ना. अच्छा नहीं है, ये फेंक देना. ये लो. पहले पेन ड्रेप करो. Sometimes if you have a gross depressions, you have a secondary case, then before to open the nose we harvest the graft. But maybe if we have a good amount of the cartilage, then there is no need. But after the harvesting we realize then the lady have the problem in, we need the graft. That's why. Otherwise rib or concal first we harvest, but it's a primary case, and in primary case we have very limited amount of the septum. Tragal cartilage, I think routine for you also. For the osteoplasty you harvest?
For
Tragal, osteoplasty?
osteoplasty,
Yeah. I think in your country, in my country, there is a lot of patient
Yeah,
of the
yes.
CSOM, unsafe ear, etiquentral disease, cholesteatoma. So for the reconstruction, we use the tragal cartilage.
Okay.
एक कुर्सी दे देना यार बहुत प्लीज आप तो बैठो ना आप तो बैठो ये दे दो so whenever you harvest the conchal cartilage either you go for the anterior approach or the posterior approach. Some people prefer the anterior approach. I usually go the posterior approach.
It's less visible for a patient. For the
Yeah.
patient.
Yeah. So posterior approach is good. So the key important thing when you harvest the conchal cartilage, always just to maintain the contour of this pinna, you always maintain the antihelix cartilage. Okay, antihelix cartilage. So either you can mark it, you can pass a needle from this side to on this side, and just you mark. This is a one way. Okay. Needle देना है दो needle देना so just like at least this 3 millimeter you should preserve
Okay.
and just you can pass this needle and another you can pass and either you can make a line and then you can mark okay
Okay, like that. Okay.
just ये नहीं चाहिए मेरे को ये रिमूव कर दे 15 number blade cautery give me the cautery yes this tooth for search just one more small bleeder so just thick. Now, yes, we make an incision in this area. Seizure. slowly, slowly. Yes, you just separate it. पेंट तो देते हैं. Yes. So this is conchal cartilage almost. Sorry. मैंने होगा ये तो. क्या? ट्रैगल और लूँ? ला. ला एक इधर पैक दे दे. ये हटा. एक 15 नंबर ब्लेड बदल ट्रैगल और ले लो. So few millimeter behind, just you left little bit to maintain the contour of tragus. Just this strip you leave.
Okay.
So just to maintain the contour.
Okay.
Suction. From another side. Yeah. So now just we do this little bit homeostasis. Okay. बाद में करेगा. इसको पैक करेंगे तो बीटा निकलेगा. इसको टूथ फोर्स दे. इसको टूथ फोर्स दे. ये होमोस्टेसिस कर दूँ एक बार. This one. Off करो. Put the peg, beat it in, and then suture it later. अद्धा वाला कॉटन वाला निकालना. Yes.
So you left the incision
Yeah.
without
in the,
sutures
yeah.
and proceed with the
Yeah. In the last we close.
okay. Last to close. Okay.
Last to close. Last to close. Now, put the self-retaining. Yes. Yes. Yes, tooth fossa. So we remove this one. Remove this one. 15 number blade. Go there. So we correct this first.
This groove.
Yes, this groove. So by the multiple scoring in this area,
So we are making the cuts, only the cuts.
yeah, we use the graft, but first we cut this.
Okay.
Lamkesh, graft है ना? Yes, now we have this graft. So now we have the different option. Then how can we use this graft? So first we check, this is the bony part, this is the bony part. Okay. So first we remove the bony part. Yes, this is bony part we remove. थोड़ा सा मैं. So this part is quite thick. This small piece of this cartilage, we use just reinforcement or reconstruction of the interior part of the septum.
Okay.
That we call the septal extension graft.
Okay.
Another method, either you can use a columella strut, but columella strut in this case is not good because this patient need a good amount of support, but that is not adequate. So ideal size of this septal extensor graft, that is around 20 millimeter width and 25 millimeter height. So just we check tooth torsion, then just we check then how can we place this one. So if we put on this side or either this side, but if we put on this side then it's better we cover this side,
Okay.
because we have the fracture. Okay, and now we check how we place it. So the important landmark, the anterior margin of this one.
Okay.
Okay, never like this, then if you create a long nose.
Okay.
If you fix it like this, then you over rotate the nose.
Okay.
So if you want like fix like this, then you derotate the nose.
Derotate.
So this is a very versatile graft. Sometimes we have some unwanted side effect also. So when we use this septal extension graft, then we use very carefully. We check columella show is good. Okay. So just ठीक है, you just pass the needle, Mukesh. Pass the needle. Yes. Yes. So now we use the suture,
Okay.
4 OPDS suture for fixation of this one. Okay. So this is horizontal mattress sutures that usually just for fixation of this. So always we use the double knot, 3 double knot for fixation. Okay, and wait for some time. Cut it. Then cut it. This part of the septum is weak.
Okay.
Deviation हो रहा है. This suture is not good because it move on this side.
Okay.
Cut it. Mukesh, काटना है. यहाँ पे ग्राफ चाहिए कुछ है, पीपी प्लेट या कुछ. because this septum is fractured in this area, so you need the support,
Okay.
something.
The septum is fractured.
Yeah.
In the place where the groove was.
Yes, yes.
Okay.
Tooth was. Cut it. Okay.
With this graft fixed, the caudal margin of the septum is,
Not beyond the
okay.
margin of this one.
Okay.
And suppose if you want to reduce this columella shoe, then just little behind this one, because
Okay.
so reduce the columella shoe.
Okay. And this exceeding anterior.
Beyond the dome, and the later you decide how much you want to the projection.
Later. You decide.
Later.
Okay. Okay.
Later.
So you can later cut it.
Yeah, we
or
cut
not.
it extra amount.
Okay.
We cut it. उनको देना 15 नंबर देना. So if this part is deviated, then we use another graft, spreader graft, for
Okay.
straightening. Huh?
नहीं है ना पैक
Pec. I just check the pec if any cotton patty is inside. No cotton patties. Because sometimes we forget cotton patty. So again we reconstruct this one,
Okay.
upper lateral and the septum. Cut. Tooth for So whenever we use the any graft, fixation that should be very important.
Okay.
How you place it. If you place it in the wrong, then rather than create the advantage, it creates the problem.
Okay.
Fixation should be proper. So now 4OPDS suture. So now we advancement of this medial crust on this graft. So what is the name of this technique? The technique is the modified tongue in groove. There is a there is a two technique. One is the tongue in groove, another is the modified tongue in groove. Suppose this both of medial crust, we suture on the native septum, that is the tongue in groove. But rather than you suture in the native septum, first you reconstruct your septum with septal extension graft, and then you advancement of this medial crust, then it called the modified tongue in groove. Clear?
Clear.
पकड़ना इसको पकड़ना. So the advantage of this suture
So you fix the middle cross.
with this extension graft, septal
Extension
extension
graft. Okay.
So advantage of this node, that the node that hide on transcolumella flap, never feel by the patient later. Here. So this suture is good. Cut it. So in this way, when you suture, then it's good. First in the septum and then होना कोई भी बोलो, सर्जरी कर रहा है. Now so the entry and exit of the needle, that should be same plane.
Okay.
Otherwise, if you have the above and down, then it create a tilted tip. So in the rhinoplasty, there are so many small things, they make the result change.
Mm-hmm.
Okay, supply irrigation. And whenever you fix your knot, not like this is wrong methods.
Okay.
Always longitudinal axis.
Okay.
Okay, cut it. Yes. पकड़ो. Now, before to put this suture, we correct this one.
Okay.
Okay. So, suppose if this deformity is diffuse too much, then we separate it, cut it, and flip it. That the technique, that is the lateral crura flip.
Lateral crura
Flip.
Okay.
But it's not diffuse, so rather than we flip it, I use a different technique. Mukesh, पहले वो देना काट ले.
What do you mean diffused? It's
Diffuse, that means tooth force of देना. Too much, like.
Okay. Okay. you make a graft.
Yeah,
Like
I make
that
a
looks
graft,
similar like a
lateral cross,
lateral cross.
and just Udina, little older. ये थोड़ी है. So I just make the more malleable. Either you can use this one, and otherwise we have this cartilage
Crushing
crusher.
crusher.
Yeah, cartilage crusher.
We use the crusher in the septoplasty.
Yes. So the pressure should be titrated, not too much, otherwise.
Okay.
Okay. Give me the scissor, and now this is small damage when
Okay,
you
yeah,
make the
yeah.
incision at that time. Okay. This is very delicate.
Okay.
Now this is little bit difficult to say for beginner pain, but once you do the more and more cases, no, graft low. If we want to change the orientation, then we cut it and fix
Okay.
sorry in new position.
Okay.
But orientation is already good. Look
Okay.
that towards
Yeah.
the lateral canthus. La, kahe cartilage? I think it's the bigger. Just we check it. Increase. Little bit bigger. Scissor. ऊपर लगा. Yes, one more needle. ऊपर लगा, ऊपर ऊपर. So we suture it now. If you have the difficulties in the beginning, then you just put the direct also.
Okay.
But this is good idea. Otherwise, sometimes in a thin skin patient, this is feel by patient. Graft feel by patient. Okay. So this is the lateral crus underlay graft.
Lateral crus underlaying graft.
Underlay graft.
Okay.
Cut. This is a 5O PDS suture.
5-0.
5O. When you create a pocket and you fix in the pocket, that is fixation is easy. Cut it. Remove the needle.
Are you going to manipulate or touch the left
Yeah,
crus also?
yeah, definitely.
Definitely.
Yeah, because look at on the image. Here the both sides.
Both side depression. Okay.
Yes. Cut it. Laterally free है क्या? वो लगा just lateral, just lateral end we fix it properly. Cut it. So now on another side, first we separate it. Scissor. कैसे कट गया? Why this?
Left side the same technique?
Left side same technique.
Okay. If you use graft on the one side, are you obligated to use the graft on the other side or not?
No, it's basically depend on. Suppose this side is surface is flat, then there is no need to use on that side, because but she have the both side depression on the teeth. Yes, this is the ideal shape. This is the ideal shape, but he earlier have like this. So if we not harvest the graft, then how can we correct it? Suture. So wherever you need the graft, definitely you harvest. Otherwise you struggle. We suture, we put it small graft unnecessary,
Okay.
and you always get consent to the patient. It's a primary patient. If it's not appear, then this patient is need the conchal cartilage. But yes, sometimes the rib graft also. But you should explain to the patient. Sometimes in a traumatic noses, in a primary case, we don't have the septum. Small septum, how can we reconstruct? Hello. Just small. Bones have the so many types of the deformity. In your country, what type of the deformity usually your patient have for the rhinoplasty, like crooked noses or the
Crook
augmented?
noses and the hump.
Okay. You have a lot of hump noses, no?
Yeah. But the rhinoplasty, it's not so popular in Europe, in
Okay.
Poland.
Okay.
Still,
Oh,
it's treated like expensive,
expensive.
sometimes unnecessary operation in the people's mind. So,
Okay.
not many people decides to make a rhinoplasty.
Cut it. मुकेश से नीडल निकालना. So where you have minor injury, then always repair. Just like we have the injured this small part, but we repair. Otherwise, create some deformity later. Okay, so what? In Europe now the preservation rhinoplasty is a new era. Okay, still थोड़ा सा डिप्रेशन है यहाँ पे. इसके लिए थोड़ा सा मेरे को वो दे कुछ यहाँ पे कुछ अंदर लगा दे. क्या लगा है? कुछ है और देना. Bone? No, no bone, no bone. Okay, small cartilage. Small cartilage. Tooth for sir. Okay. I think now better.
Yes.
Suture. Cut it. So now is interdermal suture. Interdermal suture. Okay. Why I am not using intradermal? Because we have the good definition already. Huh? So it's not necessary. Then every patient you need the each and every technique. It's your individual decision. You're the patient finding. So never too much tight or never too much loose. If you do the over tight, then you create this tent pole deformity. And this is dome equalizing suture. So the effect of this suture just evert this margin. Yeah. Okay, drill, you know. Drill connect करना drill.
There ही है, इधर ही. करो टाइगर.
वो एक सूचर और दे देना मेरे को पीछे लगाने को. पोरो वाइक्रेट PDS. Because we put only one suture, at least we use 2 or 3 suture when you open the upper lateral and the septum in this area.
Okay.
Cut it. ऊपर सब देना होगा. गोच पीस देना और वो बोन मोबिलाइजर देना एक बार. Earlier on both sides we have the depression, but now it's okay. ना उसको वो लगाना और एक फोटो वो बना देना इसका ऐसे ऐसे वीडियो इसका lateral crust का वर्तिका
Yes,
इधर आके जस्ट यूँ और यूँ हमें ही पता लगे इसको बीच में लो बन गया
yes.
एकदम ठीक now 4O vicryl so this is 4O vicryl we use as a quilting suture from superior to the
Okay.
inferior, anterior to the posterior. Because mostly people pack the nose. I never pack the nose by the merosil. I just put the simple sofratuli. Just to approximate the flap, just to reduce the collection. Anterior to the posterior and posterior to the anterior, not below to above, from above to below. So if you have any collection, that's will come down. Irrigation, cleaning, 6O vicryl rapid. Six O vicryl rapid. So now we complete of the 6th golden step. Now we move to the 7th last golden steps. Closing. So when we close it, then usually we use the 6O vicryl rapid sutures, and we use 5 tip suture closing technique. That means first suture in the center, this is the first suture, that in the center, okay, irrigation. Not like this.
Okay.
It should be longitudinal direction.
Longitudinal.
Yes, and 3 double knot always. Yes, this is the first suture. Okay, the second suture just parasagittal, just lateral to this one, like this. Mostly my instrument is the Medicon company. I think in your country also Medicon and other is the German. I think I don't know name.
Stores
Yeah, store.
mainly.
This is the third suture.
Yes.
I have the different needle holder for the particularly this suture, but somehow that is broken. So I asked to the company for new one. Whenever the people have the 6%, then I asked to the Medicon company. So 2 days he put bring the whole instrument they buy whatever they give the discount. So 1, 2, 3. Now the corner suture on either side.
Okay.
This is the fourth suture. And now the last, that is the fifth suture on that corner. So two suture are the corner suture, one at the center and two between the corner and the center. So these are the 5 tip suture closing technique. Now give me the white double prong. For marginal incision closing I use the two sutures.
Okay.
Like this, we just invert it and just
Okay.
like this. Cut it. Now two suture on another side.
Another side.
So when you close the marginal incision, you never enter the cartilage part.
Okay.
If you enter in the cartilage part, then you have a tenting. If you have a depression, so always use suture skin to skin.
Okay.
डाइस बना दी क्या? कर जल्दी कर जल्दी कर.
Explain देना.
In your country, the people like the just like a obtuse tip, like maybe they just like obtuse tip, Barbie nose,
Oh, not really.
not
Not really. Barbie nose, like. I don't
because
know.
one of patient from the Cambodia in the few months back, they just like I need like this nose, but in my country the mostly female like the straight nose.
Straight. In Poland, rather straight nose rather than Barbie nose.
You, that's good. That's good. La?
Barbie nose looks unnatural.
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 No, I am not.
People know
yeah,
that.
yeah. But you know the patient come to this celebrities like this. I need like this.
Italian favorite nose. Italian favorite.
After a long time with this nose, when we remove the plaster, then the lady, he can't decide my nose is good or bad. you know. Then after yes, my doctor asked him, your looking is very good. When my lift man asked is, you looking very nice. When she come to the OT for dressing, that man asked, now your looking is good. Then you feel, yes, yeah, I'm looking, my
Boost
looking
up
is
the
good.
confidence.
First impression is the most important.
Yeah, yeah. Yeah, that's pretty normal because the depression is gone.
Yeah.
Okay, and she has a particularly problem of this tip. Now tip is natural, and the bump has gone, and the bony base reduced, and now it's short nose. Earlier is a long nose, big nose. Projection is right. Just to put with the nice cartilage, small. Then it's finished. So if we not put the graft on either side, it's very difficult. Otherwise, you can't correct that lateral crust deformity. So lateral crust deformity, if you flip it, then for few months it is okay. But later, because mostly Indian patient have a thick skin patient, so due to the contraction again he have the depression. So if you have a splinting graft just like a underlay graft, then you have a good support, and they give the counteract the force of contractions. So later you have the good result. थोड़ा सा चाहिए बस. पानी निकाला है इसका. कैसे इरिगेशन देना. बत्ती का मेरा फ़ोन से वो बनाना.
वो वाले फोटो के साथ बनाऊं ना?
हाँ,
या पहले इसी का बनाऊं?
पहले इसी का बना दे, फिर फ़ोटो से बना दे. ऐसे नहीं, फिर मेरे को बनाना पड़ेगा. मेरे को दे एक बार दे. Just take this. एक ग्लव्स खोल दो. Now, give me the nasal speculum. पैक है कुछ अंदर? No. In every case, I use this
Silicone skin.
splint. So this is splint. Give the good pressure on this any collection or
We also use this in
Yeah.
septoplasty.
yeah, it's good. We have other one that have the airway also.
Okay.
In some patients, sometimes some patients are more panic for the blockage. So in that patient, we use that one also. Septoplasty, that is also in your country that cover in the insurance, I think.
Yes, definitely.
Yeah. In my country also the same. Sometimes when the patient come for the rhinoplasty, they just ask me, I have this insurance card. So that's the same, we just blow whatever X amount from the insurance company. Cut it. Now this is the sopratuli that usually used in the burn dressing, and some in the post septoplasty. What you pack? Marocil?
Aerosol.
Marocil. And when you remove that marocil?
Next day.
Next day. So after putting it, just little bit we press it, any collection, any seepage, just like this. Hello. So first at the center, first stair strip at the center, and the next anterior half this one, and then posteriorly, and ये बड़ी है, only the supratip part like this, scissor.
So why not on the base?
Just to release the edema.
Okay.
We usually use the POP. That man prepare the 4-layer POP. So first layer of this one. Earlier we used the tincture benzoin before to put this stair strip
Okay.
just as a antiseptic, but now we don't have. Some people use this on the forehead also. I never use. When after the 10th day, I remove my plaster. This gelonate, day after tomorrow we remove and discharge the patient.
Okay.
Now this statistic that should be longer than earlier for better. बड़ी देना है बड़ी. एक गॉज पीस. लाओ. एक मिनट रुक जा. ये और लगा दे बस. फिर इसको बंद कर देना रिकॉर्डिंग को. रिकॉर्डिंग बंद कर देना.